Zoom catheter system, it's really a complete system. It's a complete stroke solution. We've got access, the Zoom 88. We've got aspiration catheters, the 71, the 55, the 45, the 35, as well as a pump. The 88 is a large distal platform. It's designed much like a hybrid intermediate catheter. So you have a robust proximal support, but with a distal flexible tip that allows you to navigate well into the intracranial circulation, the distal ICA, as well as the M1 if needed. The 71 is intended for aspiration of large vessel occlusions in the carotid terminus, the M1, as well as the M2. The 55 and the 45 are intended for use in mid-sized vessels. And then the 35 for distal vessels, as well as to provide support to navigate your other catheters to the target vessel. The Zoom pump currently has or generates the highest vacuum pressure on the market. So it's a nice complete system. In addition, the pump is actually quite quiet, so you can actually talk to your colleagues during the case with a lot of disruption. The Zoom catheter system was designed with this bevel tip. The intention of the bevel tip was to improve the surface tip area and basically to improve the clot engagement area of the catheter. And I'll show you a couple of videos as to why this is beneficial. In addition, the bevel tip actually improves navigation. At first, when I saw this, I thought that the tip would actually impede navigation catching on vessels, but it tends to reorient itself in a configuration that allows you to navigate into the target vessel very easily. These catheters are all designed with a distal flexibility to navigate very easily in an atraumatic fashion to the target vessel. In addition to improving the surface area and the contact area for the clot, the bevel tip actually improves suction force. Suction force is proportional to the cross-sectional area of a catheter tip, and we can see when compared to a flat tip catheter, there's a significant increase in the force that's available for aspiration at the catheter tip. So we wanted to assess this in a benchtop model as well as a clinical model. And so Dr. Gunas performed a benchtop study looking at 10 flat tip 071 aspiration catheters and 10 beveled 071 aspiration catheters. We did this in a vascular phantom. And what we were looking at was the rate of complete ingestion versus corking with a thrombus model, as well as the rate of first pass efficacy and the pressure at the catheter tip. And so in this study, we found that the vacuum in both systems was essentially the same, and the vacuum is really a product of the pump and not the system itself. So just to show that all things are being equal. What we did find, or what he found, was that the bevel tip catheters actually had about 15% greater suction force at the catheter tip. And this translated to a significantly higher rate of the clot being ingested versus corking it at the distal tip. Obviously in the simple phantom, whether we corked it or ingested, all clots were removed. But the takeaway here is that we were ingesting the majority of the clot rather than corking it. And these videos kind of show that. In this first one, we can see with just aspiration, the clot is corked at the distal catheter tip and also easily removed. But this one kind of shows how quickly and how forcefully we're able to aspirate and remove that clot in its entirety. I actually can't slow this down enough to show the interaction of the bevel tip as well as the aspiration, but it's pretty impressive. So we see this on the benchtop, and it actually translates to a significant clinical benefit as well. And so to study this clinically, we looked at a retrospective review of our own experience at Prisma Health. And so over about approximately a 1-year period, we looked at only patients treated with the larger aspiration catheters, just the 71 catheter system. We had about 44 patients treated with the Zoom 71, the bevel tip catheter, and 93 patients treated with flat tip catheters, flat tip 71 catheters. And that included all the usual suspects from the competitors. The demographics in both age groups, in both groups was essentially equal. But what we did find was that there was a significantly higher rate of TICI2C or better revascularization in the bevel tip group. We also found a significant reduction in the need for bailout technique, i.e. use of a stent retriever. We can see in the 44 cases, the bevel tip catheter, we only had to use 4 stent retrievers, about 9% of the cases. And in the flat aspiration catheter group, there was about a 29% need for a bailout technique. What we also found was that there was a trend towards improved efficiency with just a one-pass effect, i.e. just being one pass and done with your case, which I think Jai kind of showed you a great example of how he was having, his average time for his procedures was about 27 minutes. And with his first case, he went down to about 9 minutes. And we're seeing that as well as in our practice. Our average time is about 15 to 20 minutes with the bevel tip catheters. And so I like this system because of its ability to navigate to the target vessel. The Zoom 88 in particular provides exceptional support, whether it's in a distal position or in a proximal position. The Zoom 88 differs slightly from the TrackStar. The TrackStar is about 15 centimeters of a distal floppy segment. The Zoom 88 is about 18 centimeters. And the catheter tends to work better with geometric anchoring, i.e. around the turns, but it provides enough support in a proximal position, even to do carotid stents in a bailout, in a tandem situation. Also, I like it because we're seeing this trend toward first pass effectiveness. And I also like it because it's got a streamlined workflow. I now have one complete system. I can tell my tech, just get me the Zoom system. It's got a durable design. Those catheter tips are durable. You're able to use it with the stent retriever. In addition, I can also do hand injected contrast runs through all catheters. So there's no need to remove my 71 or 55 if I don't want to. I can keep it kind of close to the lesion, inject or do a puff and see if I've got revascularization or if I have to re-advance my catheter. So currently my new standard setup for stroke cases is a Zoom 88 over a VTK and a glide wire. I use that for access with the goal of pushing that 88 to at least the cavernous segment. And then obviously for an M1, it's a 71 over a 35 and an 024 microwire. For a mid-sized vessel, I tend to use the 55 with the 35 and the 24 microwire. And so just a couple of examples to really highlight the ability of the system to work. I'm not going to really show the end results because I think the data already shows that, but just to kind of show you that how simple it is with just a VTK and a glide wire. We've got our VTK in the arch. We've got our glide wire up in the proximal internal, and hopefully you'll be able to see the Zoom 88 just kind of navigate up over the VTK and the glide wire. Sorry, the videos are a little wonky. I may have already missed it, but it's probably already up there in the internal. On the lateral view, you can see that we've got our wire only in the proximal cervical carotid, and the Zoom 88 actually tracks very easily without a wire across the petrous and laceral turns and ends in the posterior genu, the cavernous segment, with really no wire and minimal pushing. So it advances in a very easy, atraumatic way. It also navigates much like Shahid showed us around tonsillar loops. So here we've got a case of a 360 loop in the proximal cervical internal carotid. We've got a Berenstein insert in the common. We've got our glide wire, and we can see that the Zoom easily navigates around the tonsillar loop and easily ascends into the distal internal with very minimal effort. Now, just one more example to show its ability to navigate these turns, using it in the posterior fossa and the posterior circulation. We've got our Berenstein insert. We've got our wire up into and around the C2 and the C1 loops. And we'll see our Zoom catheter easily navigate up the vertebral artery around the C1 and C2 turns and achieve a stable position in the V4 segment. And I think here we'll be able to see our Zoom terminate here in the V4 segment. Sorry if that doesn't project very well. And then just to kind of highlight the support of the 88 and the 71 system here, obviously we've got the 88 in the posterior genu. We can see here that we've got a carotid occlusion, and the system navigates very easily through the carotid siphon around the ophthalmic bend. We've got our 35 catheter in the carotid terminus, maybe in the M1 here. And we can see that the Zoom remains the 88 remains relatively stable in the cavernous segment, and our 71 easily navigates to the target vessel. And that was after 2 passes, showing the recanalization. It also provides support when we're using other systems. So again, here we've got our Zoom 88 in the V4 segment. We've got a right P2 occlusion. This is a case with a with a Jet D and we can see the wire navigates easily to the target region. There's a little bit of resistance coming up into the basilar apex, but our Zoom 88 remains stable throughout the entire access. Also, just to kind of highlight the ability of the 55 to navigate, to those mid-sized vessels. Again, we've got our Zoom 88 kind of in the V3, V4 segment. We've got a Zoom 35 coming up into the left P2. You can see there's a little resistance, but when we use that triaxial system, we bring our 55 into the mid-basilar. It easily affords support for the 35 to navigate. And then the 55 easily traverses that kind of high arching P1 segment and gets to the P2 segment very easily. And then also just to kind of highlight, so one pass we're able to get a pretty good recanalization. There was this underlying ulcerated plaque that actually ended up reoccluding. We had to stent it, and that patient ended up doing quite well. But we're able to do it all through our platform. Just to kind of highlight its ability to navigate into distal vessels. Here we've got a closal marginal occlusion. And so we've got our 35 here in the carotid terminus. It easily navigates into the A1 across, the ACOM region into the periclosal and then to the closal marginal very easily. And then one last kind of example here, and this is where really the bevel tip showed me its ability to navigate into that distal vessel and how it aids in navigation. So we've got a distal kind of M2 posterior division occlusion here. And so we've got our wire across the lesion. If you can see, the bevel is kind of oriented in the inferior position, and it kind of catches on that bifurcation. And so we've given a couple of pushes, it doesn't go, but there's no reason to really force it. You pull the catheter back, and you'll see here, we pull it back into the carotid. It kind of reorients itself when we re-advance it. That bevel is now oriented into the superior position. Fortunately, I lost my wire access. I probably need to work on my wire skills a little bit here. But we re-achieve our wire access, and the catheter easily navigates to an area where we weren't able to get it previously. And so you can see we were able to recanalize that vessel with a very good result. And so in conclusion, I think I stayed on time here. I really like this because it's a complete stroke solution. You've got your access, you've got your aspiration catheters, and a really good pump. I found it to be extremely efficacious because of that bevel tip. That bevel tip really aids in aspiration, the increased contact area, as well as the suction force. It aids in navigation. When you do have resistance, it reorients itself, so you can pull it back, reorient, and re-advance it. And then obviously because of the clinical benefit, right? We have seen a trend towards significant increase, better reperfusion rates with the bevel tip catheter. TQ2C or better in 93% of our cases versus 74% with flat tip catheters. And then I think Shahid has already kind of shown this, that we're seeing less and less need for bailout techniques, i.e. less stent retriever usage utilizing the Zoom. Only 9% in our bevel tip cases versus 29% in the flat tip catheters. And this will translate to a significant cost savings down the road. Thank you very much. Appreciate it.